بسم الله والصلاة والسلام على رسول الله وعلى آله وصحبه وسلم تسليما كثيرا. Inshallah, today we are going to discuss some of Pediatric Endocrinology Review MCQs. This is part 1. My name is Abdulmoein Al-Agha, Professor of Pediatric Endocrinology, Faculty of Medicine, King Abdulaziz University, and this presentation is available in my website aagha.kau.edu.sa. First question: 5-year-old boy previously has been well, started to develop pubic hair, progressive nature, adult body odor, acne on the back. All these changes are changes of adrenarche. Adrenarche is a stage of puberty. In the adrenarche stage, there will be pubic hair, axillary hair, acne, change body odor, oily skin, and oily hair. So in this scenario, all has been mentioned so far are adrenarche changes. On examination, his pubic hair and penile genital changes was suggestive of Tanner stage 2. Testicular volume was 3 ml bilaterally. Here, very important information that despite we have adrenarche changes of puberty, but the testicular volume is of pre-puberty. In boys, the most important sign to differentiate clinically from true precocious puberty or pseudo precocious puberty, i.e., from GnRH dependent precocious puberty, differentiated from GnRH independent precocious puberty by measurement of testicular size. If we have a testicular size 4 ml and above, clinically suggestive of central type of precocious puberty. If we have testicular volume less than 4 ml, suggestive of precocious puberty. So here, the scenario of adrenarche in a boy 5 years of age with testicular volume 3 ml, i.e. peripheral precocious puberty, and in the pictures you could see bilateral knee hyperpigmentation, so most likely diagnosis is a non-classical congenital adrenal hyperplasia. Here some informations regarding non-classical congenital adrenal hyperplasia. Number 1, it does not manifest in neonatal period, usually non-classical. The earliest presentation is in middle of childhood, or could be in adolescent, or could be in adult, because the enzyme mutation or enzyme deficiency usually is mild. That's why they have late presentation. That's why the name is late onset congenital adrenal hyperplasia. Important information about late onset or non-classical manifestation in middle of childhood, does not present with ambiguous genitalia at all, never present with adrenal crisis. And usually the presentation comes with peripheral precocious puberty, namely adrenarche changes. Adrenarche means adrenal androgens has been released or secreted prematurely, not the actual age of puberty. Second MCQ, 5-year-old girl presented with bilateral breast enlargement. together with vaginal discharge. So here we have two symptoms of puberty. We have bilateral breast enlargement and we have vaginal discharge in a girl 5 years of age. So definitely we have a precocious puberty, because precocious puberty defined as if any pubertal sign, especially bilateral breast enlargement, happens before 8 years of age. That is the definition of precocious puberty. So this girl has, by definition, precocious puberty. Together with moodiness. Moodiness means that estrogen has been secreted, because everybody knows that the change in mood in female secondary to estrogen, as well as body odor. Body odor comes from adrenal androgens. So this girl has estrogen release, androgens release. All these changes are changes of precocious puberty. There was no relevant past medical history. What's important of that? The important that they want to exclude other pathological features or other pathological causes of precocious puberty. Especially there was no headache, no visual disturbances or polydipsia. They want to exclude pituitary or hypothalamic tumor as a causative factor for precocious puberty. As you know, hypothalamic hamartoma is the commonest cause of central precocious puberty in boys, while in girls, idiopathic central precocious puberty is the commonest cause. Here, the scenario goes toward idiopathic sort of precocious puberty. Also, they have mentioned mother and two elder sisters had early menarche at age 10 to 11. They want to tell you that 10 to 11 menarche is usual, so there was no history of familial variant of precocious puberty. On examination, the child, she was tall, she was 90 percentile, and this is what we know, complication of precocious puberty, that in childhood they are tall and they close their epiphysis early. When they close their epiphysis early, they end up as an adult with short stature. The question, which one of the following is most important investigation? They didn't tell you which one of the following is the cause. He said is most important investigation. Number A, observation of further progression of pubertal sign. Definitely, this is not the practice. We cannot leave a child with 5 years of age developing precocious puberty and just we observe. Number 2, bone age assessment is important, but is not most important. In precocious puberty, we find advanced bone age, but it will never differentiate between central precocious puberty or peripheral precocious puberty. Number C, MRI pituitary to look for sinus tumor is not important at this stage, because we don't know, are we dealing with central precocious puberty or peripheral precocious puberty? First of all, we need to know, is she having central or peripheral? So the answer is D. The most important investigation is to do basal, LH, FSH, estradiol, and then we stimulate the axis, the hypothalamic, pituitary, gonadal axis with GnRH. GnRH is gonadotropin releasing hormone agonist, is available pharmacologically, and we inject the child intravenously with this GnRH, and we see the response of LH-FSH. If there was a good response after the injection, the diagnosis will be central precocious puberty. If there was no good response or blunted response after GnRH injection, we have peripheral precocious puberty. So the most important investigation in this care is to do basal and GnRH stimulation test. If the result suggests of central, then we do MRI pituitary to look for CNS tumor. This is a picture of the child with bilateral breast enlargement. Precocious puberty could be central, could be peripheral. Central means GnRH dependent, peripheral means GnRH independent. In girls, central precocious puberty most commonly idiopathic. In boys, central precocious puberty most commonly secondary to CNS pathology, and in CNS pathology the commonest cause is hypothalamic hamartoma. Peripheral precocious puberty has nothing to do with CNS, has to do with either adrenal pathology or gonadal pathology or exogenous sex hormone intake. Very important whenever we have a child in clinical practice with precocious puberty, very important to differentiate between is this child having central precocious puberty or is this child having peripheral precocious puberty. In central precocious puberty, LH, FSH will be high, sex hormone will be high. In peripheral precocious puberty, LH and FSH will be low and sex hormone will be high. If basal hormonal analysis was not conclusive, we have to do GnRH stimulation test to look for the response of LH and FSH. Another 5-year-old of age girl brought by her mother because of bilateral breast enlargement, in addition to spotty vaginal discharge. So this is another scenario of precocious puberty. We have two signs or two symptoms: bilateral breast enlargement and vaginal discharge. On examination, see photo. What do you think in the photo? It is very clear to have café-au-lait macule. Can you explain for me the character of café-au-lait macule you are seeing in the photo? Yes, the café-au-lait seen in the photo, large in size, irregular borders, and crossing the midline. Crossing the midline. These features are classical of café-au-lait macules of McCune-Albright syndrome. Could you tell me what are the characters of café-au-lait macule of neurofibromatosis? Yes, the opposite. What do you mean? First of all, in neurofibromatosis, the café-au-lait macule is small in size, not large. Second, in neurofibromatosis, café-au-lait macule have sharp, rounded edges, not irregular edges as we could see in the photo. Number 3, in neurofibromatosis, the café-au-lait macule does not cross the midline. Here, it does cross the midline. You have to differentiate between the cafe-au-lait macule in neurofibromatosis differentiated from McCune-Albright syndrome. So this child is having McCune-Albright syndrome. But the question was not asking you what is the diagnosis. The question, which one of the following is most important confirmatory investigation? So not only most important investigation, most important confirmatory. Of course, we have to confirm McCune-Albright syndrome by doing gene mutation screening. Gene mutation screening to confirm McCune-Albright syndrome. McCune-Albright syndrome is very important for all of you to study, to read, although it's rare, but you have to know about this syndrome. To diagnose McCune-Albright syndrome, we have to have 2 out of the 3, at least 2 out of the 3 features. What are the 3 features? Number 1, polyosthetic fibrous dysplasia. Number 2, cafe-au-lait skin pigmentation. Number 3, precocious puberty. And precocious puberty is referral precocious puberty in McCune-Albright syndrome. In addition, in McCune-Albright syndrome, they could have other endocrine and non-endocrine features. From the endocrinopathy features, we could have thyrotoxicosis, we could have growth hormone excess, we could have Cushing syndrome. What is the pathophysiology of McCune-Albright syndrome? Is activation mutation of GNAS1 gene. Activation mutation of alpha subunit of the G protein. This is the classical or typical cafe-au-lait McCune in McCune-Albright syndrome. And this is the classical X-ray finding of polyosthetic fibrous dysplasia in McCune-Albright syndrome. Remind you, sometimes the skeletal survey show nothing, no changes. If you have a child with McCune-Albright syndrome and you did skeletal survey was negative for fibrous dysplasia, then second step you have to do isotope bone scan, and in isotope bone scan definitely you are going to have a focus or a spot for fibrous dysplasia. 2-year-old girl with bilateral breast enlargement. But in this scenario, only bilateral breast development. There was nothing else. No hair, no vaginal discharges, nothing. So only isolated bilateral breast enlargement. Also, there was no growth acceleration. That means that no sex hormone. Why? Because if there is sex hormone release, there will be growth spurt. But here, no growth acceleration. Indirectly, they want to tell you that there was no sex hormone secretion, no bone age advancement, and normal levels of estradiol, LH, FSH. The question, what is the most likely diagnosis? I think is very clear. Here is benign, isolated, premature thelarchy. What has been mentioned, all classical features of benign, isolated, premature thelarchy, i.e. isolated, no growth acceleration, no other pubertal changes, no bone age development or advancement, and normal levels of sex hormones. And this is some informations on benign premature telarchy. Is isolated condition. 80% happen before age of 2, rarely develop after age of 4, usually not associated with other signs of puberty, usually not associated with growth acceleration or advancement of bone age, and benign condition, no need for treatment, only what we need is observation. We need to observe the child, and most of the time with observation there will be disappearance of the bilateral breast enlargement by age of 4, and usually they have their puberty in normal age. Another girl with pubic hair, 6-year-old girl with 6-month history of pubic hair growth, associated with fine axillary hair, as well as adult odor. So here we have hair growth and change of body odor. All these changes are classical of adrenarche. There was no breast development, no acceleration of growth, otherwise normal history and normal examination. So most likely diagnosis here is isolated benign adrenarche. Isolated benign adrenarche, premature adrenarche, production of adrenal androgens happens early, usually isolated phenomena, usually not associated with growth acceleration, usually not associated with any pathological condition. Like what? Most important, we have to rule out non-classical congenital adrenal hyperplasia. We cannot say benign premature adrenarche unless we have to rule out congenital adrenal hyperplasia late onset, non-classical, and we have to rule out virilizing adrenal and gonadal tumor, as well as polycystic ovary syndrome as a cause of hyperandrogenism. 2-year-old girl presented with abdominal distension. There was a 3-month history of bilateral breast enlargement, pubic hair appearances, and rapid growth. So here, a girl with precocious puberty. Why we said precocious puberty? We have 2 signs. We have bilateral breast enlargement and we have pubic hair enlargement. As well, it's pathological. Why pathological? Because there is rapid growth. And her abdominal ultrasound in the photo showed very clear, if you could see, that actually it is CT scan rather than ultrasound, showed tumor in the liver. Which one of the following is most likely diagnosis? Here, most likely diagnosis is SCG secreting hepatoblastoma. What is the relation between SCG and precocious puberty? How could SCG involved in precocious puberty? Because HCG, human chorionic gonadotropin, in the body is similar to luteinizing hormone structure, so it functions like luteinizing hormone. So whenever we have high HCG, same as if we have high luteinizing hormone. but here the secretion not from pituitary, here secretion from embryonic tumor like teratoma or hepatoblastoma. So the final diagnosis is peripheral precocious puberty due to hepatoblastoma. Hepatoblastoma is the most common primary hepatic malignancy in early childhood. The majority of cases occur in the first 2 years of life and rarely in children above 5 years of age. It could be associated with syndromatic causes or non-syndromatic. Could be isolated phenomena, hepatoblastoma, or part of the syndrome. The syndromatic association with Beckwith-Wiedemann syndrome, trisomy 18, trisomy 21, Aicardia syndrome, and other syndromes. In this condition, in hepatoblastoma, we have high levels of alpha-fetoprotein because this tumor is embryonic in origin, and we have high HCG, human chorionic gonadotropin. Thirteen-year-old girl referred with growth failure and delayed puberty. Here we have combination of short stature and delayed puberty. And a girl 13 years of age. On examination she was short, and in the photo she has neck webbing, so most likely this girl is having Turner syndrome. But the question was not telling you what is the cause. The question saying which of the following is most likely diagnosis of hair delayed puberty. So in Turner syndrome we have gonadal dysgenesis, LH and FSH will be high. So the cause of hair delayed puberty is hypergonadotrophic hypogonadism, D hypergonadotrophic hypogonadism. We have gonadal failure, and because of no feedback inhibition, the LH and FSH will be high. And also in Turner syndrome, we could have short fourth and fifth metacarpals. What other condition in endocrinology having short and fifth metacarpals? The answer is, in addition to Turner syndrome, the other differential diagnosis is pseudo-hypoparathyroidism. Pseudo-hypoparathyroidism will have short fourth and fifth metacarpals. Ovarian failure in Turner syndrome is one of the most common cause of premature ovarian failure. So whenever you have a girl with ovarian failure, think of Turner syndrome, and you have to rule out Turner syndrome. Is a must to rule out a Turner syndrome in any girl with ovarian failure, especially 45XO. But some Turner, the mosaic form of Turner, mosaic means some cells have 45XO, other cells have 46XX. So in the mosaic form, we could have a Turner with no clinical features of Turner. Initially, mosaic, they might have a normal puberty. Initially, they could have menstruation, but with time, their ovarian function decreases and develop ovarian failure. But XO, 45XO, from the start, they have ovarian failure. This full-term neonate with isolated bilateral swollen feet, most likely diagnosis is Turner syndrome, bilateral lymphedema in feet, in both feet. And this is some information about Turner syndrome. You have to read it, especially various chromosomal types of Turner syndrome is seen in this table. So Turner syndrome, only 40 to 50% of cases 45XO. Most of the doctors, the student, undergraduate, postgraduate, whenever we say Turner syndrome, they said 45XO. Yes, true, but not in 100%. Only in 40 to 50% of Turner syndrome. The remaining Turner syndrome, they don't have 45XO. They might have a mosaic 45XO / 46XX. They might have other karyotype changes as seen in the table. So always think of other karyotype changes of Turner syndrome. Not only think of 45XO is the main karyotype changes of Turner syndrome. 10-year-old girl presented with this arm deformity in the photo. What is the diagnosis? The answer is something called mid-lung deformity. Mid-lung deformity. Mid-lung deformity. This is also one of the clinical features of Turner syndrome. And this is the classical X-ray changes of mid-lung deformity. You have to read about this deformity. I know it's very rare, but you have to read about it. 7-year-old boy has presented to the endocrinology clinic because of combination, short stature and mental subnormality. And as you could see in the photo, there is webbing of the neck. Webbing of the neck in a boy means Noonan syndrome. So the diagnosis is Noonan syndrome. Noonan syndrome is autosomal dominant disorder. The classical features of Noonan syndrome: short stature, mental subnormality, dysmorphic features, in addition to congenital heart disease. Congenital heart disease and Noonan syndrome usually involve right side of the heart, like for example pulmonary stenosis. Opposite to Turner syndrome, usually they have left-sided congenital heart disease, for example aortic stenosis, bicuspid aortic valve, coarctation of aorta. In addition, Noonan syndrome, they might have hearing defect, they have some learning difficulties, easy bruising, and easy bleeding. 10-year-old female presented with 4-week history of polyuria, polydipsia, unexplained weight loss. So we have a child with diabetes mellitus, came to the emergency room with high blood glucose and metabolic acidosis, a child of 10 years of age with decay, diabetes, ketoacidosis. The question: which one of the following is most important initial management? Shall we start with insulin drip? Wrong. Shall we start with fluid half normal saline? No. Usually we start with 0.9 normal saline fluid hydration. So the answer is D. 16-year-old boy presented with delayed puberty, He was having a recurrent episode of headache, diplopia, increased urination. So we have headache and diplopia, means there is intracranial tumor, and because of diplopia we have something compressing optic chiasm or optic nerve. So most likely here we have craniopharyngioma. Craniopharyngioma also having short stature, one of the causes of short stature. So this child was short, and craniopharyngioma, one of the common causes of diabetes insipidus. That's why this child has having increased urination and polyuria. So the answer is craniopharyngioma. Craniopharyngioma is an important topic. You have to read about it. It's a benign tumor with tendency to recur after excision. It's a rare, solid, and cystic tumor. It comes from Rathke pouch remnant. There was a wide range of symptoms. Visual symptoms is frequent. Why visual symptoms frequent? Comes from compression of the optic chiasm and optic nerve. Usually they have moderate to severe headache, and usually they have symptoms of increased intracranial pressure. Endocrine abnormalities in craniopharyngioma, usually either from direct compression of pituitary tissue or from compression of optic chiasm or from surgical removal of craniopharyngioma. The most common endocrine manifestation of craniopharyngioma is diabetes insipidus. It's most frequently observed complication. It happens in 75% of cases. Short stature is another common manifestation of craniopharyngioma, and usually secondary to hypothyroidism or secondary to growth hormone deficiency. The third common manifestation of craniopharyngioma is delayed puberty. This is MRI of the brain and pituitary, left-sided without contrast, right-sided with contrast, very clear craniopharyngioma picture in this MRI. 20-day-old neonate seen in pediatric endocrinology clinic because of hypoglycemia. On examination, he had cleft lip, cleft palate, a small mid-face. So these features of midline facial defect. In addition, the testes were palpable, but the penis was short. So all these manifestations, hypoglycemia, micropenis, in child with midline facial defect, we have to think of either isolated growth hormone deficiency or panhypopituitarism. The question, what is your best approach in order to reach to the final cause of hypoglycemia? So indirectly, what is the best approach to diagnose either isolated growth hormone deficiency or panhypopituitarism in this question? Is it to look for other small features? Will not give any other clue for growth hormone deficiency. Admit to do critical sample. It's not that important to reach the final cause because the question mentioned final cause of hypoglycemia. Do growth hormone stimulation test. In this scenario, we have midline facial defect, not that important. The most important is to do MRI brain and pituitary to look for a small pituitary size and to look for midbrain defect. This is a photo of a child with midline facial defect. Most common cause of this severe midline facial defect is what is called hollow-brows-encephaly. Hollow-brows-encephaly. And this is the cleft lip and palate. Hollow-brows-encephaly is cephalic disorder in which the forebrain of the embryo fails to develop into two hemispheres. Normally, the forebrain is formed and the face begins to develop in the 5th and 6th week of gestation. The condition, hollow-brows-encephaly, could be mild, could be moderate, could be severe. Most severe cases die in utero. When the embryo's forebrain does not divide to form bilateral cerebral hemisphere, left and right, it causes defect in the development of the face brain and in the pituitary structure and function. That's why hypopituitarism is very common association in any neonate with hollow-brows-encephaly. Hypopituitarism happens between one child in 4,000 to 10,000 live births. Congenital hypopituitarism is most often result from genetic or embryogenic pathology. The clinical presentation of hypopituitarism variable depends on the patient age, etiology, and which hormone is deficient, which may occur as isolated hormonal deficiency or could be as a multiple pituitary hormonal deficiencies. Most neonates with hypopituitarism have normal birth weight and normal length. Why? Because intrauterine life, the baby to grow does not need growth hormone or thyroid hormone. What does the baby need intrauterine to grow? They need insulin and IGF-2 to grow. So that's why if somebody with congenital hypopituitarism, congenital growth hormone deficiency, congenital hypothyroidism, all lead to normal birth weight, normal birth length most of the time. They are at risk when they born in the neonatal period of neonatal hypoglycemia. They are at risk to have prolonged jaundice, convulsion, apnea, and commonest cause of hypoglycemia in a child with hypothyroidism, either growth hormone deficiency or ACTH deficiency. Good luck. This is the end of part 1. Inshallah, we'll see you in part 2 review MCQ. Thank you.